Endometrial cancer is a cancer without any screening and without a premalignant lesion. So there's only a very little bit you have to know about endometrial cancer. So let's get through it. First, using our model, over the age of a woman's life, she generally hits menses at 11 and menopause at 51. And what you have to know about endometrial cancer is that it is a product of estrogen exposure. Estrogen exposure, endometrial cancer. Follow that alliteration. Now, of course, there are other types of cancers that are not estrogen-based. Adenocarcinoma is the one you should learn because there's a premalignant lesion and there is a source of the cancer. Learning the other one isn't relevant because it's got a poor prognosis and there's basically nothing you can do about it. So estrogen exposure, endometrial cancer. So for a premenarchal girl who has no estrogen production because she doesn't have any cycles, essentially cannot get endometrial cancer. But once you hit the reproductive age, a woman begins to produce estrogen. And she continues to do so through menopause. And estrogen has a cumulative effect, such that early on there's been very little estrogen, and by the time she gets postmenopausal, there's been the most estrogen possible. Every cycle, estrogen comes from the ovary. And estrogen exposure causes endometrial cancer. At ovulation, progesterone is made, and progesterone is protective, and it inhibits estrogen's effects. Not surprisingly then, things like OCPs, which contain progesterone, are going to be protective against endometrial cancer. Estrogen causes endometrial cancer, and the way you're going to see this is either in the reproductive age female who has dysmenorrhea, vaginal bleeding, that's weird, or in a postmenopausal female with vaginal bleeding. Knowing that cancer is not the most common form of postmenopausal bleeding, it's generally going to be vaginal atrophy or trauma. But if someone has bleeding after menopause, that someone needs to be investigated for cancer. Now, the adenocarcinoma we're talking about, following our model, is going to begin with exposure. And estrogen exposure then leads to hyperplasia of the endometrium, precancer, and then hyperplasia gives way to adenocarcinoma. Of course, the hyperplasia is going to progress through certain phases before it reaches adeno, metacystic, adenomatous, and atypical, which then gives rise to the adeno. And it's all about estrogen exposure, and there's a couple of ways you can get excess estrogen exposure. The most potent is anovulation. And not only do you have unopposed estrogen during anovulation, you also lose the progesterone effect that protects against endometrial cancer. Think of polycystic ovarian syndrome. But then other things are going to contribute to excess estrogen. And remember, it's a cumulative effect. So age matters. The older you are, the longer you've been exposed to estrogen. Nulliparity will do it as well. If you have never been pregnant, your cycles have never turned off, and that means that there's an increased exposure over time of estrogen. Obesity increases peripheral conversion of estrogen and so maintains the estrogen signal even after menopause. Getting at age, early menarche, or late menopause also contributes to the duration of estrogen exposure. And then we can actually give estrogen to her in the way of hormone replacement therapy or getting a serum like tamoxifen for breast cancer. Tamoxifen is an estrogen stimulant in the uterus. It is an inhibitor in the breast. So all of these things could be present, which increase estrogen exposure, which increases the likelihood of hyperplasia and eventually conversion to adenocarcinoma. And unfortunately, there is no screen. And the only thing we can do is biopsy in order to get the answer. And once we have the answer, we need to know what to do about it. The idea of treatment goes like this. This is the uterus, vagina, cardinal ligament, pelvic sidewall. And these are the ovaries. The cancer is of the endometrium, and it is responding to estrogen. And estrogen is a stimulant for this cancer to grow, and that estrogen comes from the ovaries. So then it makes sense that once you've diagnosed endometrial cancer, the way you treat it is to remove the mass with total abdominal hysterectomy and to remove the signal for the cancer growth with a bilateral salpingo-oophorectomy, removing the source of estrogen. Now, for worse cancers of higher stage, something that's getting out of scope for the medical student, you can consider doing radiation and chemotherapy if it's distant. And the chemo is generally going to be a carboplatin and paclitaxel-based therapy. But the core to treatment is total abdominal hysterectomy and bilateral salpingo-oophorectomy. All right, so someone comes in with postmenopausal bleeding. What do you do about it? If you see postmenopausal bleeding, there needs to be some sort of biopsy or sampling of the endometrium. And the step you take, you should not have to choose between. But an in-office endometrial sampling is about just as good as a dilation and curettage. And the way you get here is either going to be, hey, I'm complaining of vaginal bleeding postmenopausally, let's do an endometrial sampling in the clinic, or I'm being worked up for dysfunctional uterine bleeding as a reproductive age female and I got a DNC. You will not have to be asked to choose between these, but you should know how to interpret the results and what to do about it. Endometrial sampling or dilation and curettage. And one result could be it's completely negative, and that's probably vaginal atrophy. You treat vaginal atrophy with estrogen creams. And this estrogen applied to the vagina does not increase systemic exposure, worsening the risk of endometrial cancer. This is safe to use and is useful for sex, especially if she has bleeding after sex. If there is precancer, and there's only hyperplasia, and this is usually going to be found in the reproductive age female, if there's hyperplasia, you can give high-dose progesterone. And being a reproductive age female, this is usually preferred because progesterone, rather than total abdominal hysterectomy, preserves fertility. If there is cancer, that's adenocarcinoma, this is going to get a total abdominal hysterectomy with bilateral salpingo-oophorectomy. And if there are already metastases, you've got advanced stage disease. So in addition to the total abdominal hysterectomy and bilateral salpingo-oophorectomy, you'll add on radiation or chemo. Remember that it is carboplatin and paclitaxel based. Let's just review one more time what endometrial cancer looks like. The pathology is based on estrogen, and estrogen exposure increases the risk of endometrial cancer, whereas progesterone is protective. The patient will be seen in one of four classes. The most common is old and obese. They've had a lifetime exposure of estrogen and increased peripheral conversion. They may also be old and on hormone replacement therapy or a SERM like tamoxifen, where they're getting extra stimulation from estrogen exogenously. Someone who is young can develop endometrial cancer because they've got anovulation. Look for PCOS. And theoretically, a granulosa theca tumor that's not treated, that produces estrogen, could stimulate the endometrium to produce cancer, which is the only way you could theoretically get someone who's an adolescent with endometrial cancer. You should say, absolutely not, just look for the postmenopausal bleeder. All of these present with vaginal bleeding. And that's your clue that there might be cancer. The diagnosis can be made by some sort of biopsy, and that can either be an endometrial sampling or a dilation and curettage, depending on how you get there. You may see information about a pelvic ultrasound, but you should not pick this on the exam. It's useful if the endometrial thickness is less than 5 millimeters, really, really small. It means that there's probably nothing there. But if you've got someone with postmenopausal bleeding, they need a sampling, they need a biopsy in order to ensure that it's not a malignancy. If you've got hyperplasia, treat with progesterone. If you've got cancer, treat with total abdominal hysterectomy, with bilateral salpingo-oophorectomy, with or without radiation, and with or without chemo. And recognize that there is nothing we can do to prevent this, and there's no screening tool. So it becomes learning how to diagnose the condition and treat it once it's developed. That's endometrial cancer.